Welcome to our comprehensive exploration of the bones of the upper limb. Did you know that out of the 206 bones in the human body, a remarkable 64 are found in the upper limbs? Each side contains 32 bones, forming the intricate framework that supports our arms and hands. In this video, we'll walk through the major bones, their unique features, evolutionary background, and clinical significance. Whether you're a student preparing for dissection or simply curious about human anatomy, this journey will help you understand the structure and function of these essential bones. Let's begin by setting the context and understanding why the upper limb is so special. Fun fact to start, when you palpate the ulnar nerve behind the medial epicondyle of the humerus, it can make some people smile or laugh, hence the bone's playful name, humerus. This little anatomical quirk is just one example of how the upper limb bones interact with nerves and muscles, influencing both movement and sensation. As we move forward, keep in mind how structure and function are closely linked in anatomy. Upper limbs have a fascinating evolutionary history. They originated from the pectoral fins of ancient fishes. In terrestrial vertebrates, all four limbs were used for support and movement. However, as our ancestors adapted to life in trees, the forelimbs were freed from weight-bearing duties, allowing for a wide range of motion. This freedom enabled functions like grasping, feeling, and manipulating objects. Structural changes such as the development of rotary joints, the addition of the clavicle, and the rotation of the thumb were crucial. These adaptations made the human hand a powerful tool for interaction with the environment. Despite millions of years of evolution, the basic structure of the upper limb has remained remarkably consistent. The primitive pentadactyl limb ending in 5 digits is still present in humans. In some animals, like snakes, limbs have disappeared entirely, while in others, such as horses, the number of digits has reduced. In apes, the habit of brachiation, swinging from branches, led to longer forearms and elongated palms and fingers. These evolutionary trends highlight the adaptability and specialization of the upper limb across species. Studying any region of the body, it's important to start with the bones. In anatomy education, students are encouraged to palpate the bones on themselves and use loose bones for hands-on learning. This tactile approach helps in understanding the location of features and attachments, which is essential before moving on to muscles, vessels, and nerves. By mastering the bony framework, you lay a strong foundation for deeper anatomical knowledge. Each upper limb contains 32 bones, making up a total of 64 in both arms. These bones are distributed among the shoulder girdle, arm, forearm, and hand. Understanding their arrangement is key to appreciating how the upper limb functions as a unit. The bones work together to provide strength, flexibility, and precision, enabling everything from lifting heavy objects to performing delicate tasks. Clavicle or collarbone is a long bone that acts as a strut between the sternum and the shoulder. Its primary role is to support the shoulder, allowing the arm to swing freely away from the trunk. The clavicle also transmits the weight of the upper limb to the axial skeleton. It consists of a shaft and two ends, lateral and medial, each with distinct features that contribute to its function and clinical importance. Identify whether a clavicle belongs to the right or left side. Observe its shape and features. The lateral end is flat, while the medial end is larger and quadrilateral. The shaft curves convex forwards in the medial 2/3 and concave forwards in the lateral 1/3. Additionally, the inferior surface has a longitudinal groove in its middle third. These characteristics help anatomists and clinicians quickly determine the correct orientation of the bone. Clavicle stands out among long bones for several reasons. It is the only long bone that lies horizontally and is subcutaneous throughout its length. It is also the first bone to start ossifying in the body and is unique in ossifying in membrane rather than cartilage. The clavicle has two primary centers of ossification and lacks a medullary cavity. Occasionally, it may be pierced by the middle supraclavicular nerve. These peculiarities make the clavicle both fascinating and clinically significant. Shaft of the clavicle is divided into two parts, the lateral 1/3, which is flat, and the medial 2/3, which is rounded. The lateral end, also called the acromial end, articulates with the scapula to form the acromioclavicular joint. The medial or sternal end is quadrangular and connects with the sternum at the sternoclavicular joint. Each part of the clavicle has specific features and attachment sites for muscles and ligaments. The lateral end of the clavicle, the margin of the articular surface, provides attachment for the joint capsule of the acromioclavicular joint. This area is crucial for shoulder stability and movement. The lateral 1/3 of the shaft also serves as an origin for the deltoid muscle and an insertion for the trapezius, while the conoid, tubercle, and trapezoid ridge anchor the coracoclavicular ligament. Medial end of the clavicle provides attachment for the fibrous capsule of the sternoclavicular joint, the articular disc, and the interclavicular ligament. The medial 2/3 of the shaft is a site for several muscle origins, including the pectoralis major and the clavicular head of the sternocleidomastoid. The inferior surface features the costoclavicular ligament attachment and the subclavian groove, which accommodates the subclavius muscle and clavipectoral fascia. Beneath the clavicle, the subclavian vessels and cords of the brachial plexus pass towards the axilla, protected by the subclavius muscle. The nutrient foramen, located at the lateral end of the subclavian groove, transmits a branch of the suprascapular artery. These relationships are important in both anatomy and clinical practice, especially during surgical procedures involving the neck and shoulder. Clavicle is the first bone in the body to ossify, beginning in the 5th to 6th week of intrauterine life. It ossifies primarily in membrane, with two primary centers in the shaft and a secondary center at the medial end. The secondary center appears during adolescence and fuses with the shaft in early adulthood. Occasionally, an extra center may appear at the acromial end. This unique ossification pattern is clinically relevant, especially in pediatric orthopedics. Clavicle is prone to fractures, especially from falls on an outstretched hand. The most common fracture site is at the junction of its two curves, which is structurally the weakest point. When fractured, the lateral fragment is often displaced downward due to the weight of the limb. Congenital conditions like cladocranial dysostosis can result in absent or underdeveloped clavicles, leading to drooping shoulders and increased mobility. Cladocranial dysostosis is a rare congenital disorder where the clavicles may be absent or imperfectly developed. This leads to drooping shoulders that can be brought together in front of the chest. Recognizing this condition is important for diagnosis and management, as it affects not only the skeletal system but also overall posture and function. Scapula, or shoulder blade, is a thin, flat bone located on the posterolateral aspect of the thoracic cage. It has two surfaces, three borders, three angles, and three processes. The scapula plays a vital role in shoulder movement and stability, serving as an attachment site for numerous muscles and ligaments. To determine the side of a scapula, look for the large lateral or glenate angle which bears the glenate cavity. The dorsal surface is convex and divided by the spine into supraspinous and infraspinous fossae. The costal surface is concave, fitting against the chest wall. The thickest border runs from the glenate cavity to the inferior angle, helping to orient the bone correctly. Scapula's costal surface, also known as the subscapular fossa, is concave and faces the chest wall. The dorsal surface is divided by the spine into two fossae. The superior border is thin and short, featuring the suprascapular notch. The lateral border is thick and ends at the infraglenate tubercle, while the medial border runs from the superior to the inferior angle. Each border and surface serves as an attachment site for muscles and ligament. Scapula has three angles: the superior angle covered by the trapezius, the inferior angle covered by the latissimus dorsi, and the lateral or glenate angle which bears the glenate cavity. The bone also features three processes: the spine, the acromion, and the coracoid process. Each process has distinct anatomical and functional roles, contributing to the shoulder's range of motion and stability. Scapula serves as an anchor for many muscles. The subscapularis arises from the subscapular fossa, while the supraspinatus and infraspinatus originate from their respective fossae. The deltoid and trapezius attach to the spine and acromion, and the serratus anterior inserts along the medial border. These attachments are essential for coordinated shoulder and arm movements. Several important ligaments attach to the scapula, including the coracoacromial, coracohumeral, and coracoclavicular ligaments. The transverse ligament bridges the suprascapular notch, converting it into a foramen for the suprascapular nerve. These ligamentous attachments help stabilize the shoulder joint and facilitate smooth movement. Scapula ossifies from one primary center and 7 secondary centers. The primary center appears near the glenate cavity during the 8th week of development. Secondary centers appear in the coracoid process, acromion, glenate cavity margin, medial border, and inferior angle. Failure of fusion in the acromion centers can be mistaken for a fracture on X-rays, so radiographic comparison with the opposite side is helpful. Paralysis of the serratus anterior muscle can cause winging of the scapula, where the medial border becomes prominent and the arm cannot be abducted beyond 90 degrees. Another anomaly, the scaphoid scapula, features a concave medial border. Recognizing these clinical signs is important for diagnosis and treatment of shoulder disorders. Humerus is the bone of the arm and the longest bone in the upper limb. It consists of an upper end, a shaft, and a lower end. The upper end features the rounded head which articulates with the scapula to form the shoulder joint. The shaft is rounded in the upper half and triangular in the lower half, while the lower end forms the condyle of the elbow. To determine the side of a humerus, look for the rounded head at the upper end, which faces medially, upwards, and backwards. The lesser tubercle projects from the front, separated from the greater tubercle by the intertubercular sulcus. The lower end is expanded and flattened, helping to orient the bone correctly for anatomical study. Upper end of the humerus includes the head, anatomical neck, lesser and greater tubercles, and the intertubercular sulcus. The head forms about 1/3 of a sphere and is much larger than the glenate cavity. The anatomical neck separates the head from the rest of the upper end, while the surgical neck is a common fracture site. The greater tubercle has 3 impressions for muscle attachment. Shaft of the humerus is rounded in the upper half and triangular in the lower half. It has 3 borders: anterior, lateral, and medial. The anterior border forms the lateral lip of the intertubercular sulcus and the margin of the deltoid tuberosity. The lateral border is prominent at the lower end, forming the lateral supercondylar ridge, while the medial border continues as the medial supercondylar ridge. Humerus has three surfaces: anterolateral, anteromedial, and posterior. The anterolateral surface is covered by the deltoid and marked by the deltoid tuberosity. The anteromedial surface forms the floor of the intertubercular sulcus and contains the nutrient foramen. The posterior surface is crossed by the radial groove, which is important for the passage of the radial nerve. Lower end of the humerus forms the condyle, which includes the capitulum and trochlea for articulation with the radius and ulna. The medial and lateral epicondyles serve as attachment sites for muscles. The coronate, radial, and olecranon fossae accommodate the corresponding processes of the ulna and radius during elbow movement, ensuring smooth flexion and extension. Numerous muscles attach to the humerus. The subscapularis inserts into the lesser tubercle, while the supraspinatus, infraspinatus, and teres minor attach to the greater tubercle. Pectoralis major, latissimus dorsi, and teres major insert along the intertubercular sulcus. The deltoid attaches to the deltoid tuberosity, and the brachialis arises from the lower shaft. These attachments are essential for arm movement and strength. Capsular ligament of the shoulder joint attaches to the anatomical neck of the humerus, except medially where it dips down to include part of the shaft. The elbow joint capsule attaches to the lower end, enclosing the radial, coronate, and olecranon fossae. These ligamentous attachments are vital for joint stability and movement. Three major nerves are closely related to the humerus and are at risk of injury during fractures: the axillary nerve at the surgical neck, the radial nerve at the radial groove, and the ulnar nerve behind the medial epicondyle. Understanding these relationships is crucial for diagnosing nerve injuries following trauma. Humerus ossifies from one primary center and 7 secondary centers. The upper end has centers for the head, greater tubercle, and lesser tubercle, which fuse during childhood. The lower end has centers for the capitulum, trochlea, and epicondyles, with fusion occurring in adolescence. The pattern of ossification is important for assessing bone age and diagnosing growth disorders. Common fracture sites in the humerus include the surgical neck, shaft, and supracondylar region. Supracondylar fractures are frequent in children and can lead to nerve injury or vascular compromise, such as Volkmann's contracture. The humerus also has a poor blood supply at the junction of its upper and middle thirds, which can result in delayed healing. The three bony points of the elbow, the lateral epicondyle, olecranon process, and medial epicondyle, form an equilateral triangle when the elbow is flexed and aligned in a straight line when extended. This anatomical relationship is useful for assessing elbow injuries and dislocations. The head of the humerus is most commonly dislocated inferiorly. This type of injury can damage surrounding nerves and vessels, making prompt diagnosis and management essential. Understanding the anatomical relationships of the humerus helps in both prevention and treatment of dislocations. The radius is the lateral bone of the forearm, homologous with the tibia of the lower limb. It has an upper end with a disc-shaped head, a shaft, and a lower end with a styloid process. The radius plays a key role in forearm rotation and wrist movement, working in tandem with the ulna. Determine the side of a radius. Look for the disc-shaped head at the upper end and the expanded lower end with a styloid process. The interior surface of the lower end forms a thick ridge, while the posterior surface has grooves for extensor tendons. The sharpest border is the medial, and the dorsal tubercle of Lister is found on the posterior surface of the lower end. Upper end of the radius features a disc-shaped head covered with hyaline cartilage, which articulates with the capitulum of the humerus. The circumference of the head fits into the radial notch of the ulna, forming the superior radioulnar joint. The neck is enclosed by the annular ligament, allowing for free rotation, and the tuberosity below the neck serves as a muscle attachment site. Shaft of the radius has three borders: anterior, posterior, and medial interosseous. The interior border runs from the radial tuberosity to the styloid process, while the posterior border is most distinct in the middle third. The medial border is the sharpest and provides attachment for the interosseous membrane, which connects the radius and ulna. Radius has three surfaces: anterior, posterior, and lateral. The interior surface contains the nutrient foramen, which transmits a branch of the anterior interosseous artery. The posterior surface lies between the posterior and interosseous borders, while the lateral surface is roughened in its middle part for muscle attachment. These features are important for understanding the functional anatomy of the forearm. Lower end of the radius is the widest part of the bone and has 5 surfaces. The interior surface forms a thick ridge, against which the radial artery can be palpated. The posterior surface features the dorsal tubercle of Lister and grooves for extensor tendons. These anatomical landmarks are important for clinical examination and surgical procedures. Radius ossifies from a primary center in the shaft and secondary centers at the upper and lower ends. The primary center appears during the 8th week of intrauterine life, while the secondary centers appear in early childhood and fuse with the shaft in late adolescence. This pattern is important for assessing bone growth and development. Summary: the bones of the upper limb, the clavicle, scapula, humerus, and radius, each have unique features, attachment sites, and clinical significance. Understanding their structure and relationship is essential for students, clinicians, and anyone interested in human anatomy. From evolutionary adaptations to common injuries, the upper limb bones illustrate the complexity and functionality of the human body. Continue exploring to deepen your knowledge and appreciation of this remarkable anatomical region. Resort to your textbooks for deeper understanding.